All right, so we're going to talk now about asthma. We are on lower respiratory tract disorders. So the etiology of asthma, there can be a few things. Asthma is a chronic relapsing disease. It can be related to allergies, or atopy is when they're talking about atopic dermatitis or atopic disease processes. It just means that someone's immune system overreacts to a lot of things. So it's connected to allergies. Asthma can be due to exposure to irritants, or it can begin with a viral infection. Now, if someone has asthma, their airways are hyperresponsive and the inflammatory response in the airways is triggered inappropriately. So I want you to distinguish etiologies, which is causes of developing asthma, the disease, from triggers, because there's some crossover. So I have asthma because I have a lot of allergies, but if I'm exposed to an allergen, that can trigger an asthma attack. Does that make sense? So some common triggers: allergens, environmental smoke, aerosol sprays, chemical exposures, cold air, changes in the temperature or barometric pressure, respiratory infections, strong emotion, some medications. Aspirin is known to actually trigger asthma attacks in some patients. GERD or tracheoesophageal fistula, because gastrointestinal secretions can be aspirated, sulfites, hormones, and exercise. So there's a long list of potential triggers. And triggers are things that can trigger an asthma attack in a patient who has asthma. So what happens in an asthma attack? The airways spasm, so that constricts airflow. The airways swell, so there's edema in the airways, and that further constricts the airflow, but also that increases secretions, and then those increased secretions block the airway that's already narrowed. So there's three different things that narrow the airway and decrease airflow. Okay, that's important because when we start talking about what we're going to do to help that patient, we can address all three of those things. Over time, with asthma attacks, the airways sustain permanent cellular damage, so that someone who has frequent asthma attacks or who has poorly controlled asthma actually ends up with damage to their lungs. So what does asthma look like? An acute asthma attack, that patient may be wheezing, they may be coughing, short of breath, air trapping, because inspiration is easier than expiration. So they can get air in, but then they can't get it out. So they have air trapping, hyperresonance, and they develop progressive signs of respiratory distress. The medical management depends on the classification. There's a chart with classifications on page 1152, but asthma is basically classified as intermittent, mild, moderate, and severe. Some patients have only mild intermittent asthma, so they may not even take any meds, but they have an occasional asthma attack. Some patients, any patient with moderate to severe asthma should be on a maintenance medication to decrease the frequency of attacks. So diagnostic testing: pulmonary function tests are done to evaluate whether asthma is there, how severe it is, and how it responds to treatment. Peak expiratory flow is used to guide treatment at home. So this is controversial. Some providers really use it on everybody. They want them to use that peak flow meter every day. Some say it's not super helpful because the child has to be cooperative, but it can be a helpful piece of management. So what does that look like? So a peak flow meter is a small device the child blows into as hard as they can. They should do that 3 times every morning and take the highest reading. And over time, you see trends in that child's peak flow. And so their target ranges are set based on their trends. And then their target range, if they're within their target range, that's considered a green day. And so they need to only take their maintenance medications and not any additional medications. If they're slightly below the target range, that might be a yellow day. So there's a yellow range, it's a little below their target, and they might add an additional medication. If they are further below their target range, that's a red day, and they might need to contact their provider because they're more seriously struggling. So sometimes peak flow meter can help identify changes before the patient recognizes symptoms. Bronchoprovocation is used to test whether a child has reactive airways. They're exposed to either an antigen or to methylcholine or histamine or to cold, dry air to see if they have a response to that. Allergy testing can be done to try to identify triggers. They can use skin testing, or they can use, they can test blood for antigens or antibodies. A CBC might be helpful. Children who have asthma or who have a lot of allergies frequently have a very high or a higher eosinophil rate. So eosinophilia can indicate maybe this child is atopic. X-rays will show hyperinflation in an acute attack. And if someone has chronic dyspnea, the AP diameter of the chest, remember the front to back, anterior posterior diameter, may actually increase because they're using accessory muscles a lot of the time. So to manage the chronic disease, one priority is to try to limit triggers, limit exposures to those triggers. So allergen control is important. If this child is allergic to cats, they don't need an inside cat in the home. Minimizing dust in the home, and that can include covering mattresses and pillows to avoid dust buildup and dust mites. So any allergens need to be as controlled as possible. There are maintenance medications, and those medications have several different mechanisms of action. So there are different categories of medications that are used for maintenance. Commonly, inhaled corticosteroids. Corticosteroids suppress that inflammatory response. But if we take systemic steroids, there are a lot of side effects and long-term risk with those. Okay, they increase a lot of risk long-term. They also stunt growth. Kids who take a lot of systemic steroids actually lose some height growth. So rather than systemic steroids, typically they do inhaled corticosteroids. So that's going to be in an inhaler. After use of a steroid inhaler, they should rinse and spit, because the steroids sitting in on the mucous membrane can contribute to thrush. It was right there. Another option is inhaled cromolyn sodium, and cromolyn sodium suppresses mast cell activation. So it suppresses that allergic response. They can use beta adrenergic agonist bronchodilators, but for maintenance, typically that's a long-acting bronchodilator. So a long-acting bronchodilator that will keep them a little opened up through the day for a longer period of time. Methylxanthines are also used. That's a bronchodilator classification. It also has similar effects to adrenergic agonist. It triggers that adrenergic system and causes bronchodilation, and it has some of the side effects. They tend to cause jitteriness, anxiety, increased heart rate, things like that. The most common methylxanthine used for asthma on record is theophylline, but caffeine is a mild methylxanthine. And so sometimes in an acute attack, someone may sip some hot coffee or hot tea. The methylxanthines or the caffeine in the coffee or tea are bronchodilator, and the warmth relaxes the spasm. So caffeine is a methylxanthine. But you'll most often see prescription for theophylline. Theophylline has a narrow therapeutic window. So a child who's on theophylline chronically for asthma needs monitoring of those levels. Leukotriene modulators like montelukast decrease the immune response that contributes to asthma, and there are now monoclonal antibody treatments for asthma. So there's some biologics. Another option for managing chronic asthma is hyposensitization, in which allergens are introduced by injections of very minuscule amounts. That amount gradually increases, and the goal is to develop a different type of immune response to that allergen so that it makes the patient's allergy response less to that. So it's a hyposensitization. They used to call it desensitization. They don't necessarily have to have complete desensitization if they can decrease the response. And then there are things that improve respiratory function, like getting regular exercise and doing breathing exercises. So some good options for exercise for kids with asthma are things that don't expose them to a lot of allergens. So think indoor. Swimming is a really good one because not only is it usually indoors, but it is, or is it more, it can be done indoors in a pool, but it's also more, the humidity is helpful. So we want them to get exercise, but we have to try to minimize their exposure to allergens. So that's chronic disease management. Now, acute management, acute attack, they're going to get a short-acting beta agonist, and that may be inhaled or systemic. They're going to get anticholinergics, which have a similar effect to those beta adrenergics. They're going to probably get systemic steroids in an acute situation, and they may get IV methylxanthines if they're not responding to other meds. Status asthmaticus is when a patient has an asthma attack and it's not relieved despite vigorous therapeutic measures. They get oxygen to keep SATs above 90. They get beta agonist nebulizers that may include anticholinergics as well, so that ANA nebulizer. They get a systemic steroid, oral IV or IM. They get an IV to keep them hydrated and to administer meds. If they don't respond, if all of these meds are not opening their airways up, they may get IV mag sulfate, Heliox, or ketamine. Okay. At the worst case scenario, they may need intubation, and this is a patient that can die from that asthma attack. Antibiotics are not indicated for asthma attacks or status asthmaticus unless there's a known bacterial infection. So there are some risk factors. There are some people who are things that make patients more likely to die from asthma. Early onset. So if they developed asthma really young, if they have frequent attacks, it's difficult to keep their asthma controlled. Adolescents, because they don't always keep their meds on them, and they want to pretend everything's okay until it's not. If they've ever had a history of respiratory failure, any kind of psychologic condition can lead to medicine noncompliance. Misusing asthma meds. So there are patients who don't take their maintenance meds, and frequently that's because of cost. I can tell you that my daughter needs Advair, and it's $400 a month. That's not a realistic cost for the majority of people in the US. So frequently people who are misusing their rescue inhaler, it's because it's the only one they can afford. And even those have gotten more expensive. So if someone's using rescue meds all the time, they develop tolerance and it stops working. There was a nursing student in the class behind me at my nursing school who died of an asthma attack because she did not have maintenance meds. She was using her rescue inhaler multiple times a day, and she had an attack and did not respond to it, and did not get to the hospital in time. She died in the ambulance. So that's a real issue, and it's a social issue. It's financial for the individual. It's a systemic issue that so many people cannot get the meds that they need. Patients who have a barrel chest or have frequent intercostal retractions are more likely to have a fatal asthma attack and abnormal PFT results. All right, nursing care for asthma. We are monitoring their respiratory status, and we need to be assessing, is their respiratory rate coming down because they're going to have an elevated respiratory rate because they're working hard? Do they appear to have less work of breathing? Their heart rate may or may not come down as they get breathing better, because remember, a lot of the meds we're giving raise their heart rate. So we want to look at that, but it may go up with those meds. So respiratory rate coming down tends to be better. They have decreased work of breathing. We listen to them and we want to hear more air movement. Now, if we hear wheezes on assessment and we go back and assess that patient 30 minutes or an hour later and we don't hear wheezes anymore, we might think, oh, they're getting better. Make sure that you're listening for air movement, because when the airways are partially shut down, you get wheezes. When they are completely shut down, the wheezing goes away, because wheezing is air traveling through narrowed airways. If they're closed and the air can't get through, you don't hear sound. So listen not just for decreased wheezing, listen for air movement. And then we're looking at their O2 sats. Are they getting better? Are they getting worse? Are they the same? How much oxygen is required to keep them at that O2 sat? So if I've got a patient that sats are 93 on 2 liters, and I go back in an hour and the sats are still 93, but now they have to be on 4 liters to maintain a sat of 93, they're getting worse. Okay, that's what respiratory failure looks like. If they're requiring increasing amounts of oxygen, that means their lungs are not keeping up with their oxygen needs, so they're going into respiratory failure. We would be administering the meds. If a patient is taking inhaled medications, the bronchodilator goes first, and that's to open the airway so that they get better absorption of all the other meds. So if they're inhaling more than one medication, the bronchodilator goes first. After all inhaled meds, they need to rinse and spit, in particular inhalers, because they deposit a lot of stuff on the tongue and in the mouth. They need to rinse and spit to prevent systemic absorption and to prevent thrush. Also, we want patients using inhalers with a spacer. If they put that inhaler directly in the mouth, the majority of the medication falls on their mucous membranes. If they use a spacer and they're breathing in and out what's in that spacer, they get more med deeper and less in the mouth, so they have less side effects. Using steroids without a spacer can lead to a dry cough. We're monitoring for side effects of those meds. So I want you to think about, what side effects would you expect to see? Bronchodilator. Well, most bronchodilators either stimulate the adrenergic system or block the cholinergic system. Either way, they cause increased heart rate, vasoconstriction, increased respiratory rate, bronchodilation, jitteriness, nervousness, poor sleep. Think about those things, right? Steroids, think about the whole massive list of side effects that steroids have. So we're monitoring for side effects of meds. We want to help that patient into the position that's most comfortable. Usually that's upright, but they're tired. So we want to try to get them into an upright position that doesn't require a lot of energy from them to maintain. So a supported upright position. We want to remain calm and help them to remain calm. And then lots of teaching for their home care. How to take their maintenance meds, how to avoid triggers, how to use a peak flow meter if they're using that in an asthma plan, how to recognize symptoms of an asthma attack before it gets bad and what to do about it. And then encouraging the parents to allow that child to have a normal childhood. All right. We're going to start in the next section talking about some systemic disorders that affect the respiratory tract.